Good morning. Good morning, consultants, senior registrars, and registrars. I'm going to be presenting rational investigations and prescribing. Okay, I should have. And I'm going to be presenting it under the following outline. So, drugs and investigations are integral tools in any healthcare system. They not only save lives and promote health, but also used in preventing epidemics and diseases too. The concept of rational drug use is old, as evidenced by the statements credited to Herophilius 300 BC, an Alexandrian physician that says that medicines are nothing in themselves but are the very hands of God if employed with reason and prudence. So, for the meaning of rational, it means something that is based on facts or reasons and not on emotions or feelings clearly thought out. Lab tests such as blood tests and radiography are important tools for making correct diagnosis. Due to the advances in lab technology and tests and the increasing level of medical knowledge, the number of tests required is gradually increasing. The fear of litigation is also a cause of this increase in use of laboratory technology. The rational use of investigations refers to the judicious and efficient use of diagnostic tests and procedures to ensure accurate diagnosis, guide treatment decisions, and minimize harm. The test should be ordered based on the clinical indications, evidence based guidelines, cost effectiveness, and should be tailored to individual needs and preferences. Tests that cause unnecessary exposure to radiation, invasive complications, or false positives leading to further unnecessary tests or treatments should be avoided. Physicians are subject to many influences on how they order investigations. This includes scientific publications in favor of a particular investigation, commercial information, and pressures from the patient. About 20 to 25% of these tests may not be appropriate. There is a need to strike a balance. The common pitfalls in irrational use of investigations include ordering panels of tests just in case, repeating tests unnecessarily, using advanced imaging when simpler methods suffice, ignoring previous results or clinical data, over reliance on investigations without clinical correlation. According to WHO, rational use of medication is described as when patients receive medication appropriate to their clinical and related health needs in doses that meet their individual requirements for an adequate period of time and at the lowest cost to them and their community. This is from the WHO Conference of Experts in Nairobi, 1985. So this is simplified as the five rights: the right drug at the right dose by the right route at the right time for the right patient. These requirements will be fulfilled if the prescribing process covers the following steps: define the patient's problem, define effective and safe treatments, select appropriate drugs, dosage and duration, write a clear prescription, give patients adequate information and counseling, and planning to evaluate treatment responses. As we all know, irrational drug use is a global phenomenon. WHO says that antimicrobial resistance is one of the world's most serious public health problems being faced, with a major reason being the irrational use of medications. According to the WHO, globally, more than 50% of all medications are prescribed, dispensed, or sold inappropriately, and 50% of patients fail to take them correctly. Rational drug use is taking the center stage now due to the following reasons: drug explosion, efforts to curb drug resistance, growing awareness, increased cost of treatment, and Consumer Protection Act, also known as CPA. So why is there concern for rational drug use? So as summarized before, is because of drug misuse, which will lead to more health problems and unnecessary deaths. Inappropriate drug use can undo all the benefits of careful selection, economic procurement, and effective distribution of drugs. Expenditure due to irrational drug use has been a strain on the meager health budgets of many developing countries. Observed drug utilization patterns in government health facilities in this country reflect a number of unsafe or costly inefficiencies common in many parts of the world. Drug use is irrational when the prescriber uses the wrong dose or dosage form at the wrong duration, or prescribes a drug when no drug is indicated, or when the pharmacist dispenses the wrong drug or writes drug with wrong instructions, or patient does not understand or comply with dosage instructions. The factors contributing to irrational drug use include poor history taking, poor knowledge of drug use, poor communication, doctor fatigue and burnout, unavailability of drugs, cost of the drugs, and incorrect interpretation of lab results, as well as multiple prescribing. So it's important to know the difference between drug compliance, drug adherence, and drug concordance. Drug compliance is defined as the degree or extent of conformity to the recommendation about day-to-day treatment by the provider with respect to the timing, dosage, and frequency. Drug adherence, degree to which the person's behavior corresponds to the agreed recommendation by the healthcare provider. Drug concordance, new approach to the prescribing and taking of medications. Agreement is reached after negotiation with the healthcare provider and patients. The factors affecting patient adherence could be divided as provider related, which will include treatment experience, communication skills, trust and confidence, cultural and behavioral sensitivity, assumptions of adherence capacity, patient education and counseling offered, and adherence team support. Drug related. This includes convenience and fit, pill burden, food restrictions, unpleasant taste of these medications, side effects, drug interactions, and existing comorbidities. And patient related. This includes their cultural beliefs, readiness and commitment, stigma and societal acceptance, stage of illness, travel away from home, busy or if they are on holidays, depression and other psychological issues, and social network. So for the rational use of medications in Nigeria, according to the WHO fact sheet 2010, in developing countries, the proportion of patients treated according to clinical guidelines for common disease is less than 40% in the public sector and 30% in the private sector. A literature search was carried out in 5 major databases based on research carried out in various parts of the country, with a significant proportion of rational use of medication studies carried out in hospital settings, neglecting other settings such as community pharmacies. Major gaps exist in rational use of medication research in Nigeria. Less than 60% of children with acute diarrhea receive necessary ORS, yet more than 40% receive unnecessary antibiotics. Over 50% of people with malaria receive the recommended first-line anti-malaria, and less than 50% take the accurate dose. Only 50 to 70% of people with pneumonia are treated with appropriate antibiotics, yet up to 60% of people with viral upper respiratory tract infection receive antibiotics inappropriately. Common examples of irrational drug use include excessive use and misuse of antibiotics and vitamin preparations, use of injectables where oral preparations are equally effective, use of brand names when they are good generic alternatives, undue influence by pharmaceutical companies who offer a variety of gifts and incentives for prescriptions, inability or reluctance to use available diagnostic tools, treatment of patients with multiple symptoms with large number of palliative drugs rather than few essential drugs that patients can take correctly. Use of expensive medications when they are cheaper alternative with equal therapeutic effects, dispensing of medications in incorrect containers, unsafe medicines, anabolic steroids for athletes and as appetizers for children, failure of patients to use medications correctly because of inadequate instructions or understanding, and polypharmacy, the factors influencing use of drugs. So policy, legal and regulatory framework, patient and community, drug supply system, prescriber, dispenser and workplace, and lack of diagnostic facilities and uncertainty of diagnosis. So for the policy, legal and regulatory framework, absence of recognized drug regulatory authority and presence of large quantity of drugs in the market lead to irrational use of drugs, weak laws and regulations, poor social economic status. For the patient and community, demand from patients to satisfy the patient expectations and demand of quick relief. Clinicians prescribe drug for every single complaint. Patient load. Also, there's a belief that every ill has a pill, increasing the tendency for polypharmacy. For the drug supply system, promotional activities of pharmaceutical industries, the lucrative promotional programs of the various pharmaceutical industries influence the drug prescribing, exaggerated claim by pharmaceutical companies and unethical inducements. Prescriber, dispenser and their workplace, faulty and inadequate training and education of medical graduates, lack of proper clinical training regarding writing a prescription during training period, dependency on diagnostic aid rather than clinical diagnosis is increasing day by day in doctors, poor communication between health professional and patients, medical practitioners and other health professionals, giving less time to the patients and not giving enough information about the use of drugs. Lack of diagnostic facilities and uncertainty of diagnosis. Correct diagnosis is an important step towards rational drug therapy. Healthcare workers, especially in remote areas, have to face a lot of difficulty in making precise diagnoses due to non-availability of diagnostic facilities. This often promotes polypharmacy. So the cause of irrational drug use can be grouped into diagnosis, prescribing, dispensing, and patient adherence. For diagnosis, inadequate examination of the patient, incomplete communication between the health professional and patient, lack of documented medical history, inadequate lab resources, and lack of diagnostic facilities. For prescribing, extravagant prescribing of expensive drugs or branded medication, over-prescribing, that's the overuse of antibiotics and injections, and incorrect prescribing. Under prescribing and multiple prescribing or prescriber, pressure from the patients. Dispensing, incorrect interpretation of the prescription, inaccurate counting, compounding or pouring, inadequate labeling, unsanitary procedure, packaging, poor quality packaging materials, and unappealing package. For patient adherence, there could be inadequate verbal instructions, inadequate counseling to encourage adherence, inadequate follow-up or support of the patient, treatments or instructions that do not consider the patient's beliefs, environment, or culture. So what is the impact of irrational drug use? The consequences include antimicrobial resistance, adverse drug reaction and medication errors, wasted resources, eroded patient confidence in health system, ineffective and unsafe treatment, exacerbation or prolongation of illness, distress and harm to the patient, and increase the cost of treatment. So the steps of rational drug use includes the following steps. Step one is to identify the patient's problem and take a detailed history. Step two, you have to make a diagnosis of the disease and define the diagnosis. Step three, list possible interventions or treatment and identify the drug. Step four, start the treatment by writing an accurate and complete prescription. For example, the name of the drugs with dosage forms, dosage schedule, and total duration of the treatment. Step 5. Give proper information, instruction, and warning regarding the treatment given. Example, the side effects. Step 6. Monitor the treatment to check if the particular treatment has solved the patient's problem. This includes passive monitoring and active monitoring. The passive monitoring is done by the patient himself, explain what to do if the treatment is not effective or if there are too many side effects. Active monitoring, the physician makes an appointment to check the response of the treatment. Intervention strategies. Educational strategies include training of the prescribers, formal education, in-service education, supervisory visits, printed materials, clinical literature, treatment guidelines and formularies, and others. Patient education, influence opinion leader. Managerial strategies include monitoring, supervising, and feedback, health survey teams, government inspectors, self-assessment, prescribing and dispensing approaches, structured medicine order forms, diagnosis and treatment guidelines, diagnostic and treatment guidelines, course of therapy packaging. Economic strategies include price setting, capitation-based budgeting, reimbursement and user fees, insurance. Regulatory strategies include medicine registration, limited medicine lists, prescribing restrictions and dispensing restrictions. The WHO advocates 12 key interventions to promote more rational use of medications. Establishment of a multidisciplinary national body to coordinate policies on medicine use, use of clinical guidelines, development and use of national essential medicine lists, establishment of drug and therapeutic committees in districts and hospitals, inclusion of problem-based pharmaceutical training in undergraduate curriculum. Continuing in-service medical education, also known as CMEs, supervision, audit and feedback, use of independent information on medicines, avoidance of perverse financial incentives, use of appropriate and enforced regulation, sufficient government expenditure to ensure availability of medicines and staff. So what is the role of the family physician? In the context of quaternary prevention, family physicians have a responsibility to protect their patients from unnecessary and excessive tests, interventions, and treatments. According to Wonka, quaternary means identify patients who are prescribing excess medication, protecting them from new medical invasion, and to suggest to him interventions which are ethically acceptable. Family physicians as frontline providers play a critical role in promoting rational prescribing by adhering to clinical guidelines, engaging in shared decision making, monitoring treatment outcome, and educating patients. While prescribing, applying the saying, think before you ink. By prescribing those drugs, are you going to do more harm or more good to the patient? Rational use of medication could be greatly improved if a fraction of the resources spent on medicines were spent on improving use of these drugs. Ultimately, rational use of investigations and prescriptions not only improves patient outcome and reduces adverse drug events, but also contributes to the sustainability and equity of healthcare systems worldwide. So these are my references. Thank you.